Hello, everyone. Welcome to the 69th episode of the Unboxing AI webinar series by Carpool. This is our weekly series every Thursday, 11 a.m. ET, where we go beyond the buzzwords and actually unbox different aspects of AI in healthcare and in radiology. And for those of you who don't know what Carpool is the world's largest AI marketplace and an end-to-end enterprise imaging platform which helps you to build, test, validate, and clinically deploy AI in radiology right now. So, for today's session, I'm super excited about our guest, Dr. Ambika Seth. So, Dr. Ambika Seth, thank you so much for doing this.
Pleasure, Shruti. Thank you for having me.
So, I'll start with your quick introduction. So, Dr. Ambika Seth is a radiologist and a medical director at Lunit. She is leading clinical initiatives to help customers understand the capability of AI and help them embrace its impact on their daily workflows. She has formulated the clinical research strategy of breast AI for the US market and has also led evidence generation with top academic institutions in the US. Great to have you here, Dr. Ambika, today. And my first question to you would be that what drew you, as a radiologist into the world of AI, and then to your current role at Lunit?
Yeah, thanks for the question, Shruti. So I like to go back a couple of years wherein I was doing my undergrad from Safdarjung Hospital, and we had our internship wherein we were doing night duties and duties in the ICUs and the emergencies. So whenever a patient used to come in and they needed an urgent surgery, they had their pre-anesthetic check and they needed an all clear from the radiologist before they went in for the surgery, right? And sometimes the surgeons, orthopedicians had to wait for some time before they got the feedback from the radiologist. So that was one side of the story that I looked at. Then, when I went for my radiology training, then as a radiologist doing night duties, I understood that, we get a lot of load from different departments. For example, we have cases from neurology, cases from ops and gynae that require immediate attention because, again, the treatment depends on the reports. So I realized that there was a gap and there was a need that needs to be filled. And I think the timing was opportune because during that time, there was a lot of talk about AI. Again, because of the simple reason that up till that time, most of the AI models were based on machine learning, and that sort of training did not give very good results. However, there was a transition starting from, let's say, the late from 2000 onward, wherein the models were more based on the deep learning technology. They had a lot of neural layers. They could learn from millions of images that were fed into the training algorithm, and also the computing part increased. So I think everything came together at the right time, and that's how I ventured into AI for radiology.
That, that's like a very, I would say, logical journey through understanding what's happening around you, and what is your current role at Lunit? Like, what do you typically do? What's your day like?
Yeah, so I've been at Lunit for over 3.5 years now, and my role has changed over these 3 years. So I would like to take you through the journey. Initially, when I joined Lunit, I was leading clinical research projects in the US, formulating the clinical strategy. I've worked with institutes such as Emory, Mass General Hospital, to generate evidence for our DBT AI product. And after we generated the evidence, we realized that when we actually sell to the customers and the clients, there is sort of like a gap in the evidence generation versus what the clients expect from the AI or what they feel about the AI, because AI is obviously a new technology, right? So there was a gap in terms of expectations. And that is why I shifted to a role wherein now I'm working closely with the customers to help them understand the science behind the AI, how the human vision and the computer vision are different from each other. Because for me as a radiologist, when I look at a mammogram, the cancer can be very obvious. but the AI might not pick it up, and vice versa, that the AI might pick up something that I'm not able to see. And again, this is because humans are trained in a certain way. We are trained to look at certain patterns like pleomorphic microcalcifications, speculations on images and mammograms. But the AI does a pixel level analysis, and that is something that is out of perception of human bounds, right? So it is very important to understand this difference and to understand that, AI and humans are actually complementary to each other and they are not competitive. And it's only when we harness the complementary power of both that we get a truly, like, so to say, a supervision so that we can pick up more cancers and help more patients out there.
Right. And from your journey, like, almost 4 years in Lunit, so what kind of impact are you seeing with this awareness? Do you see that, just are clinicians looking at AI as a help tool in their daily workflows, or are they really looking for some transformation?
Yeah, that's a great question. So, I have talked to doctors who have, come up to me and told me that the typical waiting time for reporting a screening mammogram was around 5 to 6 weeks because they had a lot of backlog. But after using the Lunit AI technology, their waiting times have reduced to almost like zero. And I've also talked to doctors who say that their ROI, their metrics have improved, their efficiency has improved. At the end of the day, they are feeling less tired. They have more confidence in their diagnosis because specifically when you look at mammograms, at the end of the day, you are tired. You can get a dense breast, a complex case. You're not sure whether to call her back or not. And in that case, having a second set of eyes is always helpful to improve your confidence and your diagnostic accuracy.
And while you were doing your research, specifically if we talk about the US market, were there any like, insights or surprises which you uncovered while you were building this evidence with these academic institutions?
Yes. So I wouldn't call them surprises per se, but so when we talk about AI, generalizability in AI performance is a very important topic because we know that computers and machines have a tendency to be biased against certain data sets. And that's why when we train our AI algorithm, we make sure that we include diverse data sets from across the world so that the AI is not biased. Now, when we go in and do the research, our job is to make sure that we do research on, let's say, different races, different ethnicities of women, so that we know that the AI is not biased against a particular group and will not give poorer results in that particular category. So our study with Emory basically focused on the performance in different races and ethnicities. And Emory is an institute in the Europe that has a very heterogeneous population. And that's why we partnered with Emory. And the results were pretty good in the sense that AI showed a good enough performance across all the different races and ethnicities. So that instills more confidence that no matter where the woman is coming from, what her background is, she will get the best AI performance. After that, we also did a study with Mass General Hospital wherein we specifically looked at interval cancers. And when I talk about interval cancers, so when we talk about mammograms, there is a screening mammogram wherein a woman goes for her screening round, and different countries have different protocols. For example, in the US, they go in for screening once every year, right? In Europe, it's once every 2 years. And in the Middle East, it's once every 3 years. Sometimes what happens is, let's say the screening mammo is normal. Before the woman comes in for the next screening mammo, she would develop symptoms and then she would come in for another mammo between the screening rounds, and then a cancer would be picked up. These are the interval cancers, which are typically more aggressive, rapidly growing, and have worse prognosis. And that is why we conducted a study to see if these cancers could be picked up in the previous screening round rather than, presenting later when they are already pretty aggressive. And our results showed that the AI could pick up almost one third of the interval cancers in the previous screening round and also locate the correct position of the cancer. So I think that just shows that the AI vision is actually complementary to human vision and can help radiologists pick up these aggressive cancers earlier and improve patient outcomes.
Right. And I think in the mammography workflow, and again, I'm not a clinician, but I think there are two radiologists who are supposed to sign the report before it's finally published.
Yes.
What
So
is the use case
again,
of AI?
yeah. So again, the workflows differ according to the country. Like in Europe, you have double blind reading. So as you mentioned, two radiologists have to look at it separately. In the US, it's a single reading. So what we are doing with AI is we are trying different workflows to help the radiologist. For example, in Europe, one option could be the AI could replace one of the radiologists in case there is acute staff shortage. Or another option could be the AI could be used to triage the screening mammograms. Suppose a facility is getting, let's say, 100,000 screening mammograms per year. The AI could be used to triage high confidence normal cases that could probably go to, let's say, a single human radiologist. And the cases which have higher chance of cancer could still be read by two radiologists. So again, the exciting thing is that with AI, we can have different permutations and combinations and work with the doctors to understand which workflow is best for them and how they want to use the AI in their daily clinical practice.
Right. There are a few questions from our audience, and one of the questions is, breast screening in India is still limited. Do you see AI as potentially bridging this gap?
That's a good question. Absolutely. And I think in India, we have a severe shortage of radiologists and breast specialists, so to speak. So AI would definitely help in that aspect. And considering that a lot of our population is still in the rural areas, having the software reach areas where we do not have, let's say, healthcare practitioners or breast specialists would be an added advantage. For example, just to give you like an explanation, we have a tuberculosis software also for our chest X-ray products, and that is being deployed across the world in areas that are not easily accessible. So basically, they have a portable X-ray that they can carry on the machine, they can carry on their shoulders, and it requires just two people. The AI software is mounted on the machine, and with the AI results, they then decide which patients to isolate, which patients need to go in for further sputum exams. I see the similar thing happening for mammo in India also, because I have seen in my training that we used to get patients from rural areas and remote areas who had pretty advanced diseases of the breast, like they had exophytic huge masses in the breast, which were very end stage, late stage cancers with metastasis. So if we could get the AI technology to those areas, I think that is going to have a huge impact on the mortality and patient outcomes.
Yeah. And there's another question. What's the biggest misconception radiologists still have about AI in breast imaging?
I think, good question. From my interaction with radiologists who have used AI, the biggest misconception is that they always sort of compare AI and human performance, and they want AI to be as good as human doctors. I agree, it's important to have like a basic sanity check, but then again, AI vision is different, human vision is different. So instead of comparing, if you can complement the two, it's going to be a beautiful mix of like two different visions, and we can pick up more cancers and help more women.
Absolutely. There's another question from Dr. Sankalp Davar. He works with couple in our sales team. So his question is, do you foresee having different model versions specific to geographies for more accurate diagnosis? Example, different model for breast density assessment based on ethnicity.
Um, so when we talk about different models, we do know that sometimes, even though the model has been trained on a very diverse data set, it might not perform as expected in a particular center or hospital. And that is just how the AI works. So going forward, we do have plans for customization, but then again, it is pretty early to say anything about it. But definitely, there are things being planned around this.
There's another question from Youngster Ra, who asked, thank you so much for your insights. Would you say that Lunit puts emphasis on having people with healthcare background? If so, does that contribute to Lunit's success?
Uh, so we have people from very diverse backgrounds, but obviously it's a healthcare AI company. So having a background in healthcare is definitely a plus. However, we have rigorous training programs, so we can bring everybody up to speed. So that's not really an issue.
Right. So, Dr. Ambika, I think my next sort of question to you would be like, what do you think is harder, like building the AI model itself or getting it used or getting it adopted in hospitals? What's more difficult?
Tricky question, Shruti. So I think considering the times that we are in, it's probably trickier to get it adapted across hospitals again because we have the technical know-how, we have the computing power. It's the 21st century, we have great chips and everything. But when we talk about implementing the AI, it's again talking to the radiologist and having them understand that AI is a new technology. You need to trust it. There is initially a learning curve. But once you start understanding how the AI works, what are the strengths, what are the relative weaknesses, then you start trusting the AI and getting better results. So radiologists spend a lot of years during their training, and it is sort of a relearning for them, if I may put it so, to work with the AI. To give you an example, like when autopilot came in, right? Pilots had to be trained to work with the autopilot software. I see the same thing happening in radiology also.
Right. And like, what would you answer if a customer or maybe like a CTO or a CIO of a hospital whose biggest initiative for this year is like making sure that the radiology department is 5% or 10% more efficient than what it was last year. So if he asks, why should I trust AI in radiology? What would your response be?
Yeah, so I would say why 5 to 10%? You can improve your efficiency and profits by 20%. And these are not figures that I'm making up. We have evidence that speaks to the same. And just to give you an example, let's talk about the US. And in the US, we know that if a woman is at a high risk, high lifetime risk of developing cancer, she can then go in for a supplemental MRI, right? So just as an example, one of our products, that's the risk pathways, that helps the centers judge the patient's individual risk using the Cusick 8 model. That also incorporates an AI part of density, the breast density. That's a product that we have. Using that Cusick 8 model, we give out a risk score for the woman. If she is high risk, she then goes in for a supplemental MR. And obviously, let's say there is an imaging center that does both mammos and MRs. So if they have more high risk women or more women who were initially at high risk, but because they did not have the software, they did not know that the woman was high risk, right? Now with the new software that they have, they can route those high risk women for supplemental MRI, and that is going to help the imaging center. But it's not just a profit making machine, because it's going to help the woman as well. If she is high risk, she has a high lifetime risk of developing cancer, she does need to go in for a supplemental MRI, because we know that these are the guidelines by the ACR, and MRs do help catch more cancer in this subset of patients. So it's a win-win for both the patients and the CIO CTO also.
Yeah, that's pretty like interesting.
Yeah.
So like from a, I would say we've heard definitely your success story in terms of navigating and reaching at this point. But any challenge which you feel, which was like a turning point, which helped shaped your perspective on how you as a radiologist started taking AI?
uh, Challenge that I faced. Yes. So while working at Leonid, I was interacting with different doctors and helping them understand how the AI works. What I realized was that there were some doctors who were pretty happy with the AI technology, and there were other doctors who were not happy with the same AI technology. that got me thinking whether the AI performance is bad, or whether there is a difference in the perception of the doctors that makes all the difference. And that is when I realized it's all about changing your way of thinking. There needs to be a shift in our way of thinking, and to accept the new AI technology as a complementary tool rather than a competitive tool. So there are some doctors who are still stuck in this loop that, okay, this cancer, this lesion on mammo is pretty obvious to me. The AI is not picking it up, or it's picking up, let's say, vascular calcification. But then there are other doctors who understand the shortcomings and the strengths of AI, and they are using it in a better fashion. Let's say they are using it as a second blind reader, and then they are picking up more cancers and reducing the recalls. So what this was initially a challenge for me to make those doctors who were unhappy understand why they are unhappy with the AI. But then as I talked to more and more doctors, I realized it's all about how you perceive the AI and how you use the AI's strength to find more cancers.
So, and I think we were discussing this in our pre-webinar session. So this is October, I think, is just upcoming in 5, 6 days. So from your
Yeah.
perspective, what is the message, which women should definitely know about early detection?
Yes. So I would just like to say that as women, we prioritize others over ourselves. And we need to understand that our health matters as well. So go out there, get your mammogram done if you are in the right age group, because early detection of cancer has really good outcomes. So don't wait for the last moment. Don't delay it, saying that, I'll go tomorrow, I'll go later. Just prioritize yourself and get it done.
So we have a couple of more questions from our live audience. One of these questions is: do you see patients themselves requesting for AI in their screening programs, in addition to their regular screening?
Uh, Again, a very good question. So in the US, we have a model that's called the second read AI, wherein the patients opt in for AI, and they pay out of pocket. They have to pay a certain like minimal fees out of pocket for the AI software to read their mammograms. In that case, we initially educate the imaging centers. They further educate their patients when they set up a screening appointment. And we have seen that with more education and with better understanding, more patients are opting in for AI to be used on their mammograms. So, yes, patients are now proactively asking for this.
And then there is another question: do you see AI evolving beyond detection into prediction? Like who will develop breast cancer in the next 5 years?
Yes, and this is something that we at Lunit are working on. It's an image-based risk prediction. And currently, when we talk about AI, it's all about detection and diagnosis of cancer. So when there is a lesion that is detected by AI, right? But now, using the mammograms as a base, we are developing an AI that can look at the textures, look at the patterns, and look at those pixel level changes that we obviously cannot appreciate early on. And then the AI is going to give like a short term risk that who is going to develop cancer, and she can be taken up for more frequent follow-ups. And I think the beauty of AI lies not just in determining who is at high risk of developing cancer, but also determining probably who is at low risk. Because let's say somebody is at low risk of developing cancer, she can have less frequent mammograms, less radiation dose. And then I think that would make sense from a logistical point of view also, because the money that is being spent on more investigations for the high risk woman can be sort of compensated by less screening mammograms for the low risk patients. And again, it's all about personalized screening because every human being is different. So if we can use AI for that, that's the ultimate goal.
Yeah, interesting. There's one question I think where our audience wants to know, how do software engineers work with medical professionals to improve product functionalities? And I think that is always my question, because we get joined by a lot of engineers and people figuring out if they should be part of the AI league and why radiology. So what are your thoughts on that?
Yeah, so software engineers are a very important part of our teams because they are the people who actually build the product, right? The way they work with medical individuals is that, let's say they have to build an AI that picks up cancer on mammograms. So they need to understand from the medical professionals that what is like what the AI needs to pick up to define cancer, what is cancer and what is not cancer, according to medical professionals. And then when we talk about the AI output, so the radiologists, when they look at the AI results should be easy and interpretable for the radiologist. So again, that's where the medical professionals come in and they work with the engineers on the AI output results as well. And when we talk about the model, it has to be trained on certain data set. Again, the medical professionals come in and they work with the engineers on what kind of data is needed, what is the ground truth, what is the biopsy, what's the screening interval. So all these things need to be worked closely with between the engineers and the medical team.
I think there's another question from Harish Ramanatham. Why is something Lunit is uniquely doing that changes the course of this industry?
Good question. So I think Lunit is uniquely positioned because we are working on a holistic ecosystem rather than point solutions. So right now, if you look at the market out there, we have a lot of companies who have a lot of point solutions for, let's say, breast cancer diagnosis. You have PGMI solutions, you have density solutions, you have cancer detection and risk solutions. But we are working on a true ecosystem wherein the solutions would not work in isolation. There will be a lot of crosstalk amongst the solutions, a lot of feedback, and it's going to be like one seamless pathway where there will be a lot of information sharing so that the radiologist, they get the most from the AI, they get the maximum information by collating data points from all these different AI solutions.
Great. So I think that's it, Dr. Ambika, thank you so much for doing this. We try to end this on time.
It
Thank
was a
you
pleasure,
for,
Shruti. Thank you for having me with you, and thanks for the great questions. Thank you, audience.
thanks everyone. Thank you. We'll see you next week, same time, Thursday, 11 a.m. ET on the Unboxing AI webinar. Thanks everyone.
Thank you. Have a good day.
Thank you.
Bye-bye.